Good morning, good afternoon to each one of you. We're just waiting for the rest of the members to join us. Welcome to the VUMI Health Talks, the fourth edition of this year. Just waiting for the rest of the members to join us to be able to start with the speech that we will have today, which is quite interesting and will bring a lot of light in terms of how technology can help us in matters or affairs of health. Once again, we thank you all for your attendance. Once again, welcome to these VUMI Health Talks. You will just be awaiting for a minute or a couple of minutes more because we have a great audience that wants to listen to the conference of this day. So, just to be able to talk about some preliminary topics about the session of this day, as you might know, the sessions in the VUMI Health Talks are done in Spanish. Nonetheless, we will count with simultaneous or synchronous interpretation in English and Portuguese. In the next slide, you'll be able to see the instructions. There it is. You'll be able to see it in the right side of your screen where you can see the globe, where you might add the language of your preference. By default, it will come in Spanish, but you can put it in the simultaneous translation of English or Portuguese. Therefore, you'll be able to listen to the presentation in any of these three languages. So before presenting myself very quickly, also in the bottom at your right, you will find a button of Q&A. Please, any questions that you might have throughout the session, you might write it down there. And towards the end, once the presentation is finished from the team of the Clinic Universidad de Navarra, the questions will be solved. On my behalf, I am Dr. Miguel Eoavil. I'm a doctor, manager of telemedicine and programs of health and VUMI. We're developing all together with the team of VUMI and the marketing section, all these sessions, and we are covering all those topics that we believe might be of relevance for the audience that is listening to us. So without further ado, I would like to present a team from the Clinic Universidad de Navarra. But before presenting Dr. Francisco, just allow me a moment, please, if you will. So before presenting Dr. Francisco Serrano, what we want for you is for the team of the clinic to be able to present themselves as well. So with this, we would like to invite Alicia Plaza, who is from the team of corporate development of the Clinic Universidad de Navarra, who will be presenting our speakers of today. Thank you, Alicia. Welcome, team of the clinic of the University Clinic. And we do hope that everything goes well throughout the presentation. So very well, thank you very much. Good afternoon from Madrid, and it's a pleasure to welcome you all to this webinar where we will be observing directly how the treatment of proton therapy is done here in the clinic Universidad de Navarra. We would like to thank the team from VUMI, especially the marketing team, for implicating themselves in the organization of these sessions. So, we would like to dedicate some minutes to be able to talk who we are and what differentiates us as a sanitary institution. The Clinic Universidad de Navarra is the hospital of the Universidad de Navarra, which makes us a university center with three main pillars: investigation, a medical investigation, and education. This allows us to be in the vanguard of medicine and incorporate quickly the latest technical, technological, and scientific advancements. We count with 48 medical specialities and a team of professionals with an exclusive dedication in the site of Madrid and Pamplona. Our organizational model, centered in the patient and working with multidisciplinary teams, allow us to make a first diagnosis in the first 24 to 48 hours. And this is especially relevant when we're talking about international patients. From our foundation, for more than 60 years, we are specialized in the treatment of complex diseases. From our cancer center, we board the cancer with an integral focus on when therapies of latest generations as proton therapy, immunotherapy, or oncological surgery. We're also a reference center in other areas like pathology, like cardiac pathologies, pathologies of prostate, or breast pathologies. The clinic also counts with vanguard technology, with hybrid surgeons with systems of images of high precision and one of the most advanced proton therapy units of Europe. Aside of this, we're the private clinic with the greater trials in Spain and the only one that is accredited by the Joint Commission International in our country. For the ninth consecutive year, we're also the private hospital with the greatest reputation of Spain, according to the Monitor of Sanitary Reputation, and one of the best in the world, according to the ranking of Newsweek. Now, I would like to present the doctors that we have. First, Dr. Javier Serrano. He is the director of the Department of Radiotherapy and Oncology, and from the unit of proton therapy from the Clinic Universidad de Navarra. He coordinates the area of head and neck tumors, and he has a broad clinical trajectory as well as teaching and investigation. He's a specialist in diagnosis and treatment of tumors of head and neck, but also of sarcomas, lung cancer, pediatric cancer, and he's worked in reference centers as the hospital Gregorio Marañón, and he has also been trained in international institutions like the Memorial Sloan Therapy from New York and the Mayo Clinic. We also have with us Dr. Pablo Cabello, who is a specialist in hospital radiophysics here in the Hospital de Universidad de Navarra. He's a licensed in physics, formed in the Clinic University of Barcelona, where he also developed his assistential labor. At the moment, he makes part of the team of the radiophysics team in Madrid. And he works closely with the area of radiotherapy oncology. He's also been linked to university or college training, and he's been in different scientific congresses. Welcome to the two of you. Thank you for being with us, and thank you for your kind time. In first place, I believe that the important part is to be able to explain what the proton therapy is, what it consists about. Who could tell me about this? I will begin because to understand proton therapy, I believe it is necessary to also understand physics. So, the proton therapy is a type of radiotherapy. And the difference with the conventional radiotherapy is that the particles that we use will be to irradiate are protons. Normally, in radiotherapy, we use photons that we commonly know as X rays. And the features of the photons is that they deposit the dose of radiation while they go through all the matter that they might find. While the physics of protons allow for these to stop at a certain deepness and they do not deposit doses of radiation beyond this deepness required. Playing a bit with the initial speed of the protons with their energy, we can treat tumors or illnesses that are more superficial or more deep. If we're capable of accelerating the protons at a higher speed, we might treat injuries that are in a deeper state. Within the left image, what we can see just below would be the simulation of protons. And on the plot above, we can see how the doses is being deposited in its deepness. The most characteristic point is that it starts depositing less dose between a 20 to 30% throughout the trajectory. depositing almost all its energy at a given profundity, whereas where normally we will have everything that we wish to treat. And as we can see in the plot, beyond this deepness that is known as the Bragg peak, there is no dose deposited, so all the organs that are beyond this profundity will not receive any radiation. They will be saved. Here we have a very clear example of the dosimetric advantage of using protons. It has to do with the cranial spinal irradiation, where we want to irradiate the brain as well as all the spinal cord of the patient. And towards the left, we see an irradiation with photons. The conventional radiotherapy, where we might see how all the organs of the patient, the stomach, the heart, the lungs, all of them receive a certain dose of radiation, which will be lower than the one that is destined to the tumor, but can equally generate secondary effects. Towards the right, we can see a treatment with protons and how all the previous organs mentioned do not receive practically any radiation, with which we can minimize possible adverse effects. And the way that we can carry this dose of radiation to the patient, how do we launch these protons, would be the question. In the image towards the left, you can see the nozzle of our team from Madrid. That what it does is to irradiate with narrow rays of protons. In the image, we have added a small blue line that represents the size that each one of these rays of light have. As the protons are loaded particles, we can deviate them in a sense that we may cover a broader surface from in terms of what we wish to treat. In the image to the left, we have a real treatment of a patient, and we can see all those different points in that green and that light green points. We see the different points of stopping of those rays of protons. So according to the initial speed that we give to this energy, they will go more in deep or more superficial, and in function of the size that we wish to cover, we will deflect the protons with the magnets to be able to cover the tumor in the axis from left to right. In this sense, we may cover an extensive volume. This video is much more graphical, just what I was explaining with my own words previously of how the dose is of course given. It's delivered layer by layer, first with the protons of higher energy and then with those of lesser energy until we cover the volume of the treatment completely. This would be an image of the installation that we have here in the clinic Universidad de Navarra. In the central image above, we see the layout of the facility to be able to accelerate the protons up to the necessary speed that goes in about 180,000 kilometers per second, more or less half the speed of light. And we need to count for a synchrotron, which is a circular accelerator through where the ray of light starts turning until it reaches the desired speed. Once we have accelerated the protons to the speed that we require, they are conducted using magnetic fields, and they're taken up to the gantry, which is the image that we count with in the center below the screen. The gantry is a structure of 150 tons and 10 meters of height that spins around the patient with a precision of a millimeter, in a sense that we may incide with the rays of protons from different angles for the patient or towards the patient, always taking the advantage of those angles that will minimize the dose that has been deposited in the healthy tissues. It is very important to highlight that within a bottle, the size of a bottle of water, almost liter and a half, we count with 10 to the 24th protons, with which we have enough material to radiate for years. And in this video that you might see, we're once again seeing in a graphical way what we have explained, how it's accelerated in the singletron, how they're conducted up to the gantry, and how the gantry has the capability of spinning around the patient. This is where we can see the representation. So this would be the treatment room. Within these beds, the patient would go, and this is how they would see it. Over here, we can see graphically how the ray starts scanning all the volume that we wish to treat. And with this, I would like to give a step to Dr. Serrano so he could talk about the clinical benefits that are derived from these protons. I imagine, Alicia, that fundamentally it's important to know the why. We talk about these physical properties that Dr. Cabello has mentioned and why they are useful in medicine. And this is what I would like to summarize in a very quick manner throughout these images. Generally, in radiotherapy, the dosimetric benefit, what means a better distribution and consignation of the dose, is always carried throughout the years a clinical benefit. This is highly evident, and with the protons, the dosimetric benefit is more than demonstrated in locations of the thorax. It could be in the pediatric tumors of head and neck, sarcomas, amongst all. There will always be a dosimetric benefit, but the great question is how much clinical benefit will these patients have that by effect will receive it in a dosimetric manner? For this, I have brought several examples. For example, at the level of the lung cancer, the example that we share is a patient that had a cancer that aside of this also presented a chronic lung disease, and that chronic lung disease was making his lung capacity to be small. And the fact of making a treatment with proton therapy used the axis path of this lung that was ill, leaving clear the healthy lung. In this sense, it could be treated with radiotherapy of their lung cancer, preserving the lung capacity. And this is the philosophy that we have with each patient. Each time more, we have more papers and evidence, and the agencies of sanitary assessment, as well as the ministries of health and also the insurance companies, are accumulating greater evidence of the clinical benefit that this treatment can carry out. I have some examples. For example, in the esophageal cancer, there are studies and publications that talk about a clear benefit in survival and diminishment of severe toxicity when a patient is treated with proton therapy compared to a conventional therapy. And recently, in the American Congress of Oncology, it was proved throughout a random study that the treatment of head and neck cancer, specifically oropharyngeal carcinoma, presents a greater number of tumor control with a significant reduction of all the acute complications, chronic complications, sequels, and of course, medical expenses. Therefore, the cancer of head and neck is being positioned as one of those illnesses that are most benefited to be treated with protons. The proton therapy, if I had to define it in a certain way, would be the radiotherapy of the healthy tissues. It doesn't look for a superlative impact in terms of the radiotherapy treatment that will also have its evolution in time, and surely data will also show this. But the fact and the reality is that it also preserves in a substantial and significant manner all the healthy tissues. And all these healthy tissues, I've just added some examples of situations and scenarios that are typical. Who has healthy tissues that we want to preserve? The children, the pediatric patients are a clear profile that receive a huge benefit from a treatment with protons. The media, the cancer has a survival, or they will have a survival of up to an 80 or 85%, which means that this is a population that will have high rates of survival. It is not enough to have enough survivals. We must have enough survivals or with a life quality that is functional and that they can integrate themselves into society. Another profile of patients that also need to take care of the treatment of their healthy tissue or organs are the elderly population. The elderly population that in their demographic curves are becoming more frequent in society and who are patients that due to their high amount of age, their tissues have already suffered a lot of damage and they have a less reserve of functionality. They are also candidates of a treatment with protons. Tumors that are located closely or with an intimate contact with critical and vital organs, like it could be at the eyes, orbitarily, the central bone marrows, and others. These are the situations where the treatment with protons will guarantee a greater protection and a greater safety for these kind of patients. And finally, a more frequent scenario, nearly a third of the patients that we have treated throughout these 5 years in the unit of protons are re irradiations. It's becoming more frequent that patients that have been subjects of treatments of radiotherapy some years ago, throughout the years, they can have a relapse that may be treated once again with radiotherapy, and technologies as proton therapy will allow to do this treatment with safety. And the treatment in a low dose, or just as we call it, integral dose, when we need to treat a tumor that is localized in the site, and we avoid to irradiate dispersed dose in others. There are many clinical scenarios that have demonstrated that it increases the survival rate. It increases the risk or decreases the risk of having mobile or chronic illnesses when they are subject of unnecessary radiation at a cardiac, lung, or a pathological level, amongst others. We also spoke about children before. Now, the treatment with proton therapy with children has demonstrated that the cognitive deterioration and the functional state and hormonal development that these pediatric children have when they become adults are clearly superior to the historical or classic data than when they have been treated with conventional radiotherapy. In this study, that is a paradigm, they analyzed and compared in long term, which was the functional state and the evolution of twins, where one of the twins was treated with radiotherapy, conventional radiotherapy, because they had an oncological disease, and the twin didn't suffer this. The evolution in the long term is that compared to its twin, they had a greater risk of complications and even morbid mortality. Therefore, avoiding the unnecessary radiation in children is fundamental. And talking about the elderly population, we see this demographic evolution, which is becoming a higher percentage of our society due to a double factor. A purely demographic factor of longevity, we have a greater life expectancy, but also a greater survival rate of those patients that have suffered from a cancer. So we have two factors that make this patient profile, this fragile elder patient, is becoming greater. I would also like to mention something that I believe is very important, and it's the assessment of efficiency or the cost efficiency assessment. Now, the treatment with the protons is a limited treatment worldwide at the level of Europe and the rest of the world. Therefore, it's logically a scarce good that requires a cost and an investment that is highly important. We're talking, therefore, of a treatment that is significantly more expensive than a conventional treatment with radiotherapy that is much more universal. Nonetheless, when you analyze entertainment, which is the impact of sanitary costs to a patient that has been submitted to a conventional therapy or a treatment with proton therapy, this study that was published by Lindy Anderson, we can see that a patient with a cancer of head and neck that was subject of a conventional therapy versus another one with proton therapy, initially the expense is low, the impact is lesser, but in the long term, if you see the evolution of these graphics, the risk of complications, re-incomes, new interventions, and all the derivation of an unnecessary irradiation or complications post-treatment are greater. Therefore, the treatment with proton therapy at a medium and long term is cost efficient. And finally, I would just like to say that the treatment with radiotherapy within the spectrum of the treatment of cancer has a fundamental weight. About a 60 to 65% of the oncological patients will require radiotherapy at a certain moment of their lives. This on one side. And on the other side, almost 50% of the patients that reach a healing or a resolution of their cancer have been in part have are due in part or totally due to a treatment with a radiotherapy. So the radiotherapy has an estimation, and this is a study from the European Society of Radiotherapy. These studies or these actions will increase throughout the next decades, reaching important numbers, and the proton therapy will play a fundamental role within this context. And finally, and to conclude with this small review of the clinical evidence and the application of the proton therapy, I would like to talk about our experience. Within the numbers that we assessed in the first 1,000 patients, we observed that on one hand, the functional status of the children to which had been treated was a percentage of 25 to 30% of these patients was excellent, with a high survival rate and in about an 85%, and with a functional state that is brilliant. This is a child from Ecuador. She's from Mindarga. She makes part of the many children that we have treated that proceed from Center and Latin America. And for this child, it was her last experience. She almost obtained a 10 in her grades. So this reiterates the benefit in the long term that these type of treatments have. And the great novelty that we were going to see is that we are going to observe the treatment of a patient in real life. I don't know what steps does the patient need to follow until the moment that they are treated, which are the different phases or stages until they get to this point. Yes. Let us mention a bit about the case of this patient that we will be looking at in just a moment. The steps that a patient follows in proton therapy begin with the simulation, radiotherapy, and proton therapy. It is very important to have the capability of reproducing the position of the patient throughout each treatment session. To ensure this, we will use systems of immobilization, such as these that we see below. These are the three that we have used with this patient per se. Towards the left, we have a thermoplastic mask, which is made of a material that when it heats, it becomes moldable and it allows to adopt the form of the patient. And and we can immobilize their head and neck for it to be reproducible. In the center, we have an immobilizing board where this mask is anchored towards. And to the right, we have a headrester that is customized, that is done with a special clay that at the moment of getting wet, it becomes moldable and it allows to adapt the head of the patient. Once we have located the patient with all these systems and allowed him to gain a position where the oncological and the radiotherapist conceived that is the adequate to receive the treatment, it is proceeded to perform a TAC from the patient. This TAC image will be the one that we will afterwards import in our software of planification, and it will allow us to calculate how the dose is being deposited and those or such volumes that we wish to irradiate. In this image, we have our patient, how they would be immobilized in a position that will be reproduced throughout all the days of such treatment. In the second stage, once the patient has been subject of this simulation, which traditionally requires the study of a scan or a TAC, and that is currently being complemented with additional images that could be resonances, PET, and others. With all of this, we were able to build a three-dimensional reconstruction of the patient where we segment and rebuild all its organs and structures. And what we also do is to start limiting the zone. In this case, we have a patient that had a relapse in the base of his skull from a nasopharyngeal cancer. And in this area that needs to be treated, we can rebuild it three-dimensionally. So once it's delimited, we can define which is the best approach or the best planning so that the beams of protons deposit the energy and the dose within the site that we wish to treat. Once we have all these elements, from the physical side, what we do in the first place is to be able to see what entries or which angles are best to be used so that the dose is deposited where we wish and avoid in its path the organs and risk. And we must also ensure that such entries that we use are reproducible. For this case, where we have a skull treatment, we will try to avoid entries through the nose that could present a filling. We will try to avoid going through the ear conduct, which can be positioned in a different way every day. And as in this case, as we have a centralized injury, we have used two incidences that are more or less symmetric and more or less 80 degrees in one side and 80 degrees on the other side as well. Once we have defined our incidences, we proceed to indicate the planning software, how we wish to make the distribution of our beams of radiation. Just as we have mentioned before, these beams of radiation will have different energies in terms of the deepness or the profundity that we wish to treat. And we will detect in the axle from left to right and function of the volume that we wish to irradiate. In the planning system, what we need to indicate is what margin do we wish to use for this irradiation and how together or how separate we would like to have these beams of radiation and function that we're interested in a lesser time of treatment or a better integration of the dose. In this image, we might see how the dissymmetry would be left, how the volume that has been defined as a tumor or a volume of treatment is covered by the high dose of radiation, while the rest of the organs only or barely receive any dose. This image is a sample of such statement. Towards the left, we can see how the eyes or the optic nerves barely receive radiation. And in the plot towards the right, even if it's a bit technical, you may understand that what we have towards the right, which is the volume of the treatment, are receiving the highest doses, while all these lines that are towards the left are those wrist organs that are receiving lesser doses than those that we wish to treat. And all of this is interesting to see in a planning software. That's beautiful. But we do need to ensure that what the computer is calculating can be really reproducible when we're irradiating the protons within our equipment. For this, we have verification systems based on acrylic lattice and ionization chambers that allow us to measure our plans of treatment before irradiating the patient and compare it with what we've planified. We have some criterias of verification that are highly strict. And in case this irradiation does not comply with them, we would take a step back, and we would replan. Thank you very much to the both of you for that detailed explaining of the unit as well as the case that we shall be seeing in just a moment. And I believe that this is the most important element. Let's see this. So we will go towards the treatment room. And on the meantime, we wish to give you a video of Dr. Diego Ascona, who is a specialist of hospital radiotherapy, who will be explaining how this unit of proton works from the inside. Thank you very much. So, the proton therapy is a modality of radiotherapy that employs protons of a high energy to treat the tumor. The advantage of the protons is that they're able to release the dose in the tumor, freeing healthy tissue. This is conceived thanks to the physical property of the proton, which is its mass, the weight, all the weight it has. You might see that the body is formed by atoms, and the atoms has the greater mass, and the core of the core is like P, well, the complete mass is like a field of football, so most of the space is empty and it's occupied by neutrons that are spinning. So the clear is that the proton has 10,000 more weight than an electron, and it collides fundamentally because it sees electrons. And when the proton clashes, it simply changes its side of movement. So the proton basically follows a straight direction. So if we control the energy and the speed of the proton, we can control the point where it stops. More initial speed, greater penetration of the patient, less speed, less penetration. Achieving protons of high energy is not easy, and it requires a very complex installation. So we will make a virtual tour. Here, the point is the cyclotron. You might see the images. The cyclotron has a ring, and within these rings, we have magnetic fields that spin to generate these protons. So they're confined in a space, and an electric field that is in charge by the different magnets that we have in each corner. This generates an impulse, so it increases its speed. They are accelerated, if you will. It's very important to mention that the protons are go at 60% of the speed of light, 180,000 kilometers per second. So towards the end, the acceleration, they're giving 5,000 spins per second. Once the proton comes out, the proton is injected in the line of the beam that has 5 meters, where they have magnetic sustainers to be able to focalize the spin of light or the beam of light. This line is connected with the gantry, which is as a spinning unit where we can spin to be able to incide the patients with different entry points. This will be seen in the treatment room in just a moment. In a typical treatment, we will give 2 or 3 fields so that the dose goes to the tumor and the healthy tissue receives a lesser dose, and it's really decreased in the relevant quantity. It's very important to also position correctly the patient. This is where the gantry counts with a system of guided image, diastonic tomographer, with which we acquire a set of three-dimensional images from the patient that help us to register them with the planning, so we can reposition the patient. Patient will every day be positioned in an optimal manner, and they will be always positioned as the initial day that it was planned, so that the beam of protons that allow us to give that high dose where we're interested and limited where we're not interested to go gives us that need to apply it in the correct point with the tumor. So in the test of image and giving a correct position is fundamental to be able to pull out the greatest benefit from the proton therapy, provide the fresh dose where it needs to go, and constrain the dose where it doesn't need to go. Thank you very much to all our colleagues for allowing us to see how, from in the inside, this unit of protons work. And we're about to go into the room of treatment, and I'll give the word to the doctors who will explain it in an infinite better way than I could do so. Very well, let us follow the path. This would be the entry towards the bunker, or to the vault, and as it's useful in this treatment units, it has a way of a maze as a measure of protection. Once we have gone through the maze of the entry, we go into the room, and the room, as you might observe, the central element would be this chair or this table, where the particularity that it counts with is that it only has one leg, and it has the capability of making all the movements of those 6 degrees of angle of the movement of the patient. This will allow us to include a high versatility in terms of how to adjust the patient within the treatment. The patient will be positioned here through these devices. Over here, we can have what we count with the box or the treatment table that is attached to the table. Here we have the head positioner that Dr. Cabello was mentioning. And this small point here is to support the legs. The patient is positioned here. Over him, we will position the mask that we have here. And this mask, which is the one that we built at a certain moment for the treatment at the moment of the simulation, is the one that will ensure that the positioning is perfect and agrees with what we are looking for. Once the patient is positioned, what we will do is to make a convinced CT, which is a tech of low resolution, but allows us to take three-dimensional images of the position of the patient. This is something we will see in a moment. And if you will, Dr. Cabello, rest of the elements that we count within the room, in the first place, we have a laser system that allows us to reproduce the position of the patient. It gives us a benchmark of where the patient should be located at. And this huge cylinder that we have is the gantry inside. If we went through a door that we have in the back, you would see how the complete structure is about 10 meters of height. And from the gantry, we would have this structure that we know as the nozzle, which is where the protons are shot from. It also counts with two panels and two X-ray tubes that allow us, just as Dr. Serrano has mentioned, to be able to create a tridimensional image with the patient in the sense that we can compare it with the planning tech and ensure that the positioning is being reproduced in a perfect manner. And towards the end, we can also see a small tray where we can add additional elements that would help us to modify the beam to precisely generate energies of protons that would allow us or help us to have more efficient treatments. So, if you will, we can go through the room of control, and afterwards, we would go through all these steps in the collocation and mobilization, verification, and put in treatment, but looking at from the room of control. Here in the room of controls, I would expect that the patient is about to come in to start with the treatment. And here, what they can tell us is what is the labor that is done here? What is done here? What's the work that goes from this control room? Basically, this would be the heart of what the daily functioning would have in terms of the proton unit. And I would like to highlight the work that the technicians do. The specialist technicians in radiotherapy make part of our professional team, and their labor is essential because they play a fundamental role in all the steps of the treatment. In the simulation, they are the responsible ones of the collocation, construction of devices, and the creation of devices of images. And in the part of reconstruction of organs and the delimitation of the treatment, they play a very important role. And that's where we have another technicians that are the symmetrists, and the ones that work in the unit are also superior technicians, operators that are dedicated to the care of patients and the treatment of the patients within the units. So if you can see within the chamber, we, we have our patient who is being positioned within the table by our colleagues or our fellows of radiotherapy. They are added into the table that we have that we have there with the device that we use to relax the inferior members or the legs. And above all, we have the headrest and the mask. This mask is the one that will allow for the patient to start the treatment in an adequate position at the moment of receiving the treatment. It's the position that we, in principle, use to be able to start with the treatment. Within this other console that we see below, we'll be able to see how the TAC images that will be generated from the accelerator or the gantry will be transported here. They will be fused here. And this is where we verify that the patient has the correct position to receive the treatment. How long can the treatment of a patient take? How much does it last? The complete session could take about 25 minutes to half an hour. Most of the time is precisely this, what we're seeing. Positioning the patient, trying to reproduce the position of the day of the simulation, and the verification with a radiological image. Now, the radiation with the protons per se could last from 2 to 3 minutes, not more. And it also depends on the function of what we're treating. Smaller volumes are irradiated in a lesser time, greater volumes. And once the patients are within, you try to provide the best experience that they can have, but the most comfortable position, that it's a brief position, and that they can feel comfortable. Can you let us know about this? Usually, in all the radiotherapy services, that's the main intention, the main attempt to be able to achieve the immobilization, a positioning that has the fair balance between being comfortable and not an excessive uncomfortable position, because we have the mask, we have thermoplastic sheets, we have many devices that try to ensure that the patient will be located in a correct position. And in a certain manner, it needs to be tolerable with the patient so that the collaboration that we require from the patient, that they're relaxed and at ease throughout all the process, can be maintained. If a patient is excessively uncomfortable or they find themselves in a situation with pain or bad position or uncomfortable, they won't achieve the desired results. And use in a habitual dynamic that we have, especially with children, with an internal audio that we have, you usually let the patient tell us what they prefer to listen at the moment. Some people prefer to listen to radio, to listen to a song, to listen to a series or cartoons. But the matter of fact that if they have in their environment something familiar, makes that these minutes that they have to be in the unit are more comfortable for them. So we are beginning with the treatment. I don't know what else can we see, Dr. Cabello, in terms of what we will start seeing. Well, in principle, what we're doing is that we're verifying the image. As you might see, here we have the image of the scopia, where they have taken a radiological image of the patient. It has been rebuilt as a scanner. And what we will be doing is to merge the images that were obtained throughout the day of the simulation with those images that we have just obtained in direct. Once these images have been merged, you can see if the fusion is perfect, there will be a minimum discrepancy 0.2, 0.1, 1 millimeter, and it will be within the range or the threshold of tolerance. Now, if there is an adjustment required because the collocation is deviated and more than a millimeter or two, what we would automatically do is to give the order in the table so that that small adjustment or that small discrepancy can be corrected immediately from the table. And we're precisely observing this where what we're doing is to merge the image from their simulation as well as the image that comes from our TAC device. At the moment that we click and fuse or merge, you might see that it coincides perfectly. The orange image is the image that we have just recently obtained, and the blue image is the image that was obtained throughout the day of the simulation. And our range of tolerance will always be below 3 millimeters. Yes, I understand that the precision is a very important value, right? Well, in protons, it's fundamental. Yes, and if well, in the conventional treatment, it's relevant, but in the protons, it takes a greater relevance. For this, the physicists, instead of only looking at the positioning, we also are in charge of all the controls, the quality controls that ensure that the machine will be working in a manner that is completely reproducible. For this case, where we have these small discrepancies that we have seen in the image, will be corrected with the table. You can see that every day in the morning, we can ensure ourselves that effectively the table is capable of making these corrections, and aside of it, that they do it in a precise manner. Every morning, we perform a daily control that allows us to guarantee this and that the beams of radiation correspond with everything that was commissioned throughout the first day. And now that we have verified that the collocation is exact, that the images coincide, that a minimal correction that I believe was a millimeter, millimeter and a half has been done, we will know when this is all done that the patient is ready to be treated. This is when we start with the treatment plan that radiophysics developed at its moment. And this is what we will be observing precisely in the next dashboard. Our technician fellows have added the nozzle and the angle that we planned, 80 degrees. And currently, what we're doing is to request to the synchrotron to accelerate the protons to the planned speed. It will take just a moment while the machine reaches its ideal point. And for example, at the moment, you can tell us how many patients are treated per day in this unit. We have an average of 30 to 32 patients. We usually start or begin at 7 a.m. with a quality control. And this initial period of the morning, just as Dr. Cabello has mentioned, is used precisely for the quality control, verify that everything is ready every day. Then we start with all the pediatric treatment that will request, for example, sedation with anesthesia will be in the morning, and then the rest of the day up to the evening is what we take. And the average is 30 to 32 patients per day. And yes, taking into account as well the pediatrics patients. But at the moment, we're also treating lung, prostate, head, neck, sarcomas, or many pathologies that, just as we have mentioned, are subsidiaries to receive the benefit of a treatment with the proton. So the irradiation has begun. And with this template that we see in the screen, we may observe in the first place the layers of the different profundities or deepnesses that are being irradiated. Just below, we may observe how the beams of radiation are directed towards the points that have been programmed. We can see how it irradiates layer to layer with different energies. And these elements that are reproduced every 3 or 4 seconds, these sounds, are because the cyclotron have to accelerate a new beam of protons at the necessary energy. And all of this is done in a very fast manner. So in about 30 seconds, we will be finishing with this treatment. Very well. Let's let the patient receive its treatment. We have seen how it's begun. And if you all will, we can go back to the initial room where we will be able to start observing the different questions that have emerged, those that have been formulated. We'll try to answer them in the remaining time. And on the meantime, we'll give you another video that we have prepared about the first 1,000 patients that have been treated in the unit of proton therapy in the clinic Universidad de Navarra. Since 2019 up to the moment, 6,000 visits have been done, 3,500 pediatric anesthesias, 143,000 spins of the gantry, 300 visits to the gantry, 150 visits to the accelerator, and 20,000 sessions have been performed with 45 accredited professionals in rotation. 68 concerts with the national hospitals, 4 with international hospitals, and more than 1,500,000 euros invested within 30 different units. 54 professionals of the area or the department, 1 engineer, 1 pediatrician, 3 secretaries, 5 nurses, and 6 technicians are in the area. 1 manager, 1 radiology pathologist, 7 oncological treatment, and 7 radiotherapists are included. 31% are pediatric patients, 69% are adults for different reasons. In the adults, the most representative are sarcomas in the central nervous system, head and neck as well, are the most representative treatments. International patients come from these different origins. 1,000 patients in the unit of proton therapy. Very well, we have returned to the room where we started from, and let us start reading those questions that we have received from the different attendees. Miguel, if you will, please go ahead. Well, in first place, I thank them from my side, and on behalf of VUMI, our congratulations. It's a fantastic and incredible work. So we have different questions, and we will try to give an answer to all of these questions as well. So, comparing the benefits of the proton therapy versus the conventional radiotherapy. Can the proton therapy be used in all the cancers as a substitute of the conventional radiotherapy? I would imagine that this question is more directed towards me from the three of us. I surely believe that we need to understand a clear concept, which is that the proton therapy is radiotherapy. Radiotherapy is any treatment that use ionizing radiation for a therapeutical use, especially in oncology. While we try to make the digestive of proton therapy and radiotherapy might take us to a confusion, but they're all radiotherapies. And this is what Dr. Cabello has explained that they use protons, and sometimes the radiotherapy has a great amount of dispersion. It doesn't have the precision in terms of the dose that the protons can facilitate, but the proton therapy is radiotherapy. And I punctualize in this and I highlight this fact because what we need to think when you're in a scenario of the indication of a treatment for a patient, it's not an indication of proton therapy or radiotherapy. It's the indication of a radiotherapy. If a patient is the candidate of being benefited of radiotherapy, because afterwards the technique of radiotherapy that is used is a secondary aspect. In a certain occasion, it will require a treatment with tomotherapy or a treatment with radiosurgery or the treatment with a common VMAT or a CRT or with proton therapy. But the step before is for a patient to require a treatment with radiotherapy. In other words, a patient that does not require radiotherapy will not receive the benefit from proton therapy or any other of radiotherapy. Mentioning this, of course, the proton therapy may be used with the adequate systems of control, with the systems of immobilization, verification, respiratory control, etc. They can be used in all the tumors where there's an indication of radiotherapy. What this unit of proton therapy needs to bring together are all the systems of control and verification and control of uncertainty that are required for a complete case. For example, for a brain, it could be in a way, for a lung, it could be in another manner, and for a prostate, it could be another one. But the response very quickly is yes. Any patient that requires radiotherapy would be a subsidiary to be treated with protons. Okay, I think we're about to finish, but we have time for a last question. We have a person that was asking if there's any counterindication for the proton therapy. Counterindication would be the same one that we could use for the treatment with ion radiotherapy. There are different situations where the term and syndrome of hypersensitivity could make you question even if the radiotherapy is indicated in the treatment with ionizing treatment. These syndromes that are genetic syndromes are just one of those indications of protons because they are situations where the body reacts in an exaggerated manner to radiation. And usually the radiation is counterindicated, but if it emits one, in any case, it would be protons. And then any other counterindication of protons, where they have received previous radiation to doses that are completely unsurpassable, or the risk that it could take us to a re-irradiation could be excessive. They are the same as with the conventional radiotherapy. There is no clear counterindication. There is an indication in general of a treatment with radiotherapy. Can we go towards a last question? There's an interesting question that we have around. Just to clarify a bit further of what's been mentioned, considering the advantages that we've had in terms of the proton therapy compared to a conventional radiotherapy, what clinical criteria or anatomical criteria are the most determining to be able to opt or to decide to going through the proton therapy or the conventional radiotherapy with a modulated intensity? If you will, I can also answer. Well, I believe that this is something that Dr. Cabello also agrees with me, I believe. My point of view, or our point of view, is that we consider that the proton therapy is another technique that, if it wouldn't be a scarce resource, just as I mentioned at the beginning of the exposition, it's a scarce resource worldwide. I think that we wouldn't even contemplate these matters where it's indicated or not. It's indicated for any patient that requires radiotherapy. As it's a scarce resource, I can talk about our experience in Spain. In Spain, other entity in Madrid, as we in the Clinic of Navarra, we were the first two in 2020 that started to walk with the proton therapy. And all the sanitary system of Spain began a process of criterias of selection of patients to be channelized and derived towards us centers. As it's such a scarce resource, we began with the cases where there was a greater consensus or a greater agreement in terms that the benefit would be enormous. In the first position, we have the pediatric tumors. Patients with pediatric tumors that we mentioned before would be an indication without question. Patients that have localized tumors in the base of the skull, fundamentally in chordomas and chondrosarcomas that are also located at the level of the spinal cord and that in many occasions invade the medullary channel, are also other clear indications. Afterwards, after this, tumors with cancer of head and neck, re irradiation of patients that have been submitted to previous irradiations, patients with sarcomas, abdominal as retroperitoneal. There are many spectrums of patients that will receive a clear benefit with the treatment of protons. Without going beyond, a woman, a patient that is a woman with a cancer in their left breast that has a previous pathology of the lung or the heart, and that submitting them into an irradiation of that left breast could take us to a risk in a medium or long term of cardiotoxicity. Well, let's say that we have demonstrated the benefit in our experience that we wouldn't irradiate absolutely any part of the heart or the lung, and this will take us to a dosimetric benefit that is much more clear. But that would be the spectrum up to the moment. Just another question, doctor. And in the case of the international patients, how can we value them? If, for example, a patient wishes to come and be treated in the clinic, how would that process go? Usually, we have an international department that works magnificently. We have a quantity of people that are in a constant contact with us. And usually, this starts with a request of a report of a second opinion, where we, from the department, what we will always request is the greatest amount of clinical information, medical reports, radiological images in a DACOM format to process them and analyze them. And if the patient is a potential candidate to a treatment with protons, the next step that we will always carry out is to manage and put in and to go ahead with a video consultancy. And this video consultancy, before having any displacement or any other step, is when we land a case, we clarify the doubts, we emit a report of recommendation, and if everything towards the end mentions that it's a case where the patient is a candidate and it's logistically carried on, this is when they are moved to be attended, valued. They can go through all the process and they can be treated. Within these 5 years, we have treated a percentage, just as you have seen in the video, very important number of international patients. And our dynamic and our international team of support is very fast. Can I can I make a last question? That is a two in one. I believe this has been mentioned again, but this could be a clarification. If you treat only localized tumors, or in the case of a metastasis, it could be associated to other therapies as chemotherapy, but in this case, it would be excluding itself. No, I go back to the main premise. With the conventional radiotherapy, the treatment of the metastatic patients and the state of oligometastatic, which means a controlled metastatic illness, is done normally. They made a radiosurgery of the brain of metastases. They make a stereotaxic radiosurgery. ECBT, it's done in the lung, the liver, and many different structures. In a theoretical manner, it's completely contemplated that whatever you can do with a conventional radiotherapy can be done with protons. But I go once again back to the essence. The limited resource makes you screen where you will receive greater benefit and where less. If I have to irradiate brain metastasis and I could do it with photons, with radiosurgery, with an precision and an accuracy that is submillimetrically, perhaps the treatment with protons won't give me any other benefits in that concrete case. But it's not because of the metastasis, it's because of the indication and the resources. And the second part of the question, of course, it can be associated with chemotherapy. And all the patients that we treat with lung, head, and neck also received common treatment with chemotherapy. And associated to this, it means that in post surgery, where the radiotherapy is many times indicated, it would also fit, right? Yes, completely. Yeah, just to give you this message, every indication of radiotherapy is potentially an indication of a proton therapy. And I believe this is a message that is important for all of us, right? The proton therapy is a topology of radiotherapy, obviously, with all these benefits and advantages that you have demonstrated. Just an additional question. Have you had patients not only on the side of Latin America, but also in the United States? We would be talking on the northern side of this world. Have you also received patients from North America? We have received patients from Canada. We've had patients from the east of Europe. We've had Asian patients. We've had African patients. We have had patients from all the Arabic Peninsula, the Emirates. Australia would be the only site that we still need to explore. And any immediate annoyance after the prototherapy and the first days? Or are they normally asymptomatic patients after receiving the proton therapy? It varies. It depends on the cases. One case doesn't have to do with the other. Normally, the tolerance at a medium and long term is infinitely better with the protons. Recovery and the physical state of a patient 2 years later is so much better. And in an acute case, the zone that is being irradiated will logically suffer the inflammation and the normal symptoms of that site that you're irradiating, exclusively of that zone. But it's variable, and you couldn't talk about it in a general manner. I'm sorry, I'm just trying to answer some questions. Some of them have been responded. And in fact, all indication of radiotherapy is potentially a proton therapy because this answers most of half of the questions. What is the element or the radioactive that is used for the protons, or is it directly a use of the protons? I believe that this question is definitely for Dr. Cavejo. Usually in proton therapy and in radiotherapy, usually we do not use any radioactive elements. This radiation is artificially generated. In this case, what we count with is with a bottle with molecules of hydrogen. And what we do is that through a very strong electrical field, we separate the protons from the electrons and we accelerate them in the synchrotron. Therefore, there is no radioactive element per se. We just grab the particles and we accelerate them to be able to launch them against the patient. Very well. I will be mentioning this because I think you already mentioned this, but the counterindication for the proton therapy would be the same that we would have for the radiotherapy. That's what I would understand, the same as the indication. There are studies that I believe you showed that could show a rate of healing and how long, or how would they be compared with the conventional radiotherapy? Up to the moment, the greatest level of evidence that we count with are the studies that I have shown, and they are fundamentally based where we have a greater evidence of the benefit is not so much in the control of the disease or in greater survivals free of illness. I believe that the greatest benefit is in avoiding complications and reducing toxicities and being able to increase the quality of life and reduce any relapses or any sequelae. I have showed the children that have a cognitive deterioration or hormonal problems of growth and development. I've also mentioned the complications in the esophageal area. And we're observing that what I just added in my first slide, that a dosimetric benefit, a better dose throughout time will carry out to a clinical benefit. The first clinical benefit that we're observing is that the patients tolerate it better, that they respond in a long term with a better life quality. It reduces the complications, and this in the long term would also carry better clinical results. But up to the moment, most of the evidence that exists is based mainly in the reduction of the secondary effects, complications, sequelae, and a better quality life. What advantage would we have in treating it in a cancer center properly as the one that we have in the clinic? Not only because of the treatment and the therapy, but because of the center that we have here. Well, when you mentioned before, I'm accustomed of coming from a great hospital center like Diego de Marañón, where I trained myself and where I was for 2 decades. And no service of oncology or no department can live isolated in the back from a hospital. All our patients are enormously complex. The great virtue that the clinic or that the cancer center has is that the unit of proton therapy is a piece more within all the cancer center of all the team of radio diagnosis, from all the team of lab, of urgency, of anesthesia, of surgery. We make part of a full team because no patient will require only the participation of a professional or two. They need the participation of a full team, and we are charmed to make part of this cancer center, which I believe is the correct space to be able to treat a patient with cancer. Very well, Miguel. If there's no further questions, you gave me the opportunity, Lisette, to make another question. The quantity of sessions or the amount of sessions would be the same as with conventional radiotherapy, or does it depend on the case? It depends on each case. In a pediatric patient, the conventional radiotherapy and the proton therapy are subject of pediatric or international pediatric protocols. The COP, which is the maximum organism of oncology and science of oncology, stipulates that each child will be treated due to an international protocol, be it a sarcoma, blastoma, or neoplasia. All these protocols will be similar to international protocols, and all in different locations with different types of illnesses. We would have the same trend that is being presented in the last decades by the modern therapy. It says light hyperfractioning, which means that treatments that were done previously some years ago in 8 weeks can be done in 4 weeks, or treatments that used to take 5 weeks can be done in one. So the incorporation of lipofractioning will, in general, be implanted at the level of general therapy, and the proton therapy is not an exception. We usually use similar schemes to those that we would use if we were working with conventional radiotherapy. Perfect. Thank you very much, doctor. Thank you very much to the two physicians that are with us. Thank you very much, Alicia. And I don't know if you would like to make some closing words for our audience that have been in about 200 today. If you would like to give some final words. Well, for us, it was a pleasure to share this moment with all of you. We are charmed of receiving international patients. We do expect that it was interesting enough, that it was didactical enough, and that we were able to transmit the complex and at the same time the how well worked we have all this radiotherapeutical process that we have to be able to transmit the safety and trust in our cancer center, and that we're always at your availability and your disposition whenever you require it. And I would like to thank Miguel for allowing us to participate in the VUMI Health Talks, also to the doctors for sharing this knowledge with us, and the team of the clinic Universidad Navarra for opening the doors and explaining in such a well manner how the unit of protons works. We would like to thank all the team of the clinic Universidad Navarra. And in effect, doctor, I believe that the complex was made simple. We could understand it. And this is highly valuable because a well informed patient is a patient that will collaborate in a better way with every treatment. On the side of VUMI, we would like to thank the clinic Universidad de Navarra. We would like to thank all the audience. And as you might know, in this month of May, in the month of May, we will have another session at the VUMI Health Talks. It's an invitation you will be receiving. So we would like to thank you all. We hope you have a nice day, a nice afternoon, or a nice evening, depending on your geography. Thank you very much.